Bismillahirrahmanirrahim. Now we are going to start with the ENT session of the pediatrics. So let's get straight into it. The very first topic is about the differentials of the stridor. We have talked about that before, but like in the last section about I don't know. Uh, I don't remember. I think it was general principle or something. But now let's do that again. So croup is caused by the parainfluenza virus in most cases in fall or winter. The stridor will be inspiratory or biphasic stridor with a barky cough and infectious symptoms. Foreign body aspiration with or without choking episode. Inspiratory stridor or wheeze and focally diminished breath sounds. Chronic, so these are like group and foreign body aspiration are causes of acute stridor, and chronic or anatomic causes of stridor include laryngomalacia, vascular ring, and something, and airway hemangioma. So the floppy supraglottis, prominent age 4 to 8 months. In laryngomalacia, inspiratory stridor worse with feeding, crying, or supine and improves when the patient is put in a prone position. So it is inspiratory stridor, right? For the foreign body aspiration, we also have an inspiratory stridor. And for the group, inspiratory or biphasic stridor can be there. Vascular ring, great vessels encircle or compress the trachea, and there will be biphasic stridor that improves when the neck is extended. Airway hemangioma. Hemangiomas enlarge in the first few weeks of life. Worsening biphasic stridor, concurrent skin hemangioma, like there will be beard distribution of the airway hemangioma. Then we have laryngomalacia. Causes are chronic. It causes chronic stridor. Pathogenesis is caused by the floppy supraglottic structures that collapse during inspiration. Time period begins in the neonatal period and loudest at 4 to 8 months. Presentation: inspiratory stridor, worse in supine position, and exacerbated by feeding or upper respiratory illness. Prone position improves the symptoms. Diagnosis: uh, the diagnosis is mainly clinical and is confirmed with direct laryngoscopy and flexible fiber optic laryngoscopy. Findings: there will be omega shaped epiglottis, collapse on supraglottic structures during inspiration. Management: spontaneous resolution by the age of 18 months. Treat those patients accordingly who have GERD. Give anti-reflux therapy. Patient with refeeding difficulties, cyanosis, or failure to thrive should be referred to the surgical consultation. So there is a table about that. Laryngomalacia pathophysiology: increased laxity of the supraglottic structures. Clinical presentation: inspiratory stridor which worsens with the supine when supine and peak at age 4 to 8 months. Diagnosis is usually clinical and confirmation by the flexible laryngoscopy for moderate to severe cases. Management: reassurance for most cases and supraglottoplasty for severe symptoms. Then we have this picture about the mid inspiratory stridor in the laryngomalacia. So in the start of inspiration, the airway is patent, right? When the air is entering, but since the air is moving due to increased velocity of the passage of air through the airway tract, there is a negative pressure that builds inside, and this negative pressure allows the airway to collapse, and there can be arytenoid collapse, as you can see in this picture. Because of this negative pressure, the wall of the trachea or the supraglottic structure they just collapse. So this is thoracic cavity. When it expands, intralaryngeal pressure drops below the atmospheric pressure. Floppy larynx collapses, and turbulent flow will cause inspiratory stridor. They can be biphasic stridors as well, but mostly they are inspiratory stridor, as we saw in this table. They were saying that it is mostly inspiratory stridor, but biphasic. No, I'm sorry, that was group. For laryngomalacia, we have inspiratory stridor. Okay, I just forgot about that. For laryngomalacia, we always have inspiratory stridor. Okay, now let's move forward. So here is another picture in which they are showing something which I can see right now. Yeah, now you can see it. Normal larynx, it is epiglottis, and this is airway. Okay, so omega shaped epiglottis, like this is omega, and laryngomalacia happens, and the airway is no more patent. Tracheomalacia, the above one, this one was laryngomalacia in which supraglottic structures were collapsing. Now we have tracheomalacia. So in tracheomalacia, during inspiration, intrathoracic pressure decreases during inspiration, while during expiration, intrathoracic pressure increases during expiration, and that collapses the trachea. Okay, because the intrathoracic pressure is also pushing the trachea inwards, so that causes the trachea to collapse. And something. Yeah, that makes sense because air moves fastly in the upper airways and then it moves onward into the trachea. When the thorax is expanding, there is also an outward traction on the trachea which keeps it patent. But as soon as we start expiring, the thorax is moving inwards. On top of that, we have air moving from inside the trachea that will collapse that trachea. The next thing is about the laryngeal papillomas. Treatment is surgical debridement. So these are the normal vocal cords, and there we have an endotracheal tube inserted inside, and there we have the recurrent respiratory papillomatosis. These are the papillomas and true vocal cords, and endotracheal tube is present like this. The next thing is the causative organism is, I'm sorry, there was an interruption. So, yeah, we were talking about the causative organisms. That is HPV type 6 and 11. Presentation is hoarseness, airway obstruction, repeated operative interventions. Appearance of the lesion is finger-shaped, warty, grape-like. Dark red punctate areas corresponding to the blood vessels can be seen. Okay. Treatment is surgical debridement. Next topic is about the otitis externa. Actually, these notes are taken from the UWorld. These are the like you may think that these are haphazard, but these are not haphazard. These are very well confined in compiled notes. Actually, these are topical. These are arranged in accordance to the UWorld. Like whatever the question is coming in the series, the topic that is addressed in that question is written in these notes. So this is how these lecture series are working. If you may find it problematic a bit, so I'm sorry, I just wanted to make it clear that what is the order of this whole thing. So more common in children and adolescents, also called as swimmer's ear. Otitis externa is called as the swimmer's ear. Okay. Occurrence after swimming in the outdoor water sources. Cerumen is acidic and protective against infection. Cleaning of cerumen by swimming or excessive cleaning can lead to otitis externa. So when you do excessive swimming or do some activity which is causing an excessive amount of water to enter your ears, that washes away the cerumen which is acidic. So when that is washed away, there is a fair chance for the bacteria to grow, and that leads to otitis externa. That is also called as swimmer's ear. The most important organism for the swimmer's ear is Pseudomonas aeruginosa. Tympanic membrane is spared, clear and not inflamed, and no middle ear fluid is seen. Consider wig placement to facilitate the medication delivery. Then we have otitis externa. Risk factors: water exposure, trauma like with a cotton swab, foreign material, for example, hearing aid and headphones, dermatologic condition like eczema and contact dermatitis. Microbiology includes Pseudomonas aeruginosa and Staphylococcus aureus. The clinical manifestations include otalgia, pruritus, discharge, and hearing loss. Pain with the auricle manipulation and ear canal erythema and edema and debris. Treatment is remove the debris. Topical antibiotics like fluoroquinolones, which cover both organisms like Pseudomonas as well as Staphylococcus, and you can also give glucocorticoids to settle the inflammation. Candida otitis externa. It is seen in otitis associated with a foreign body, for example, hearing aid and the fruiting bodies. So that is Candida otitis externa. Yeah. So this particular type of otitis externa is caused by the foreign bodies, and you can find the fruiting bodies inside that. Acute otitis media. There will be purulent fluid and bulging of the tympanic membrane. This is the normal ear and normal tympanic membrane. While in the case of otitis media, this is what a tympanic membrane looks like. It is bulging outwards. Bulging tympanic membrane, erythematous, purulent fluid can be seen behind the tympanic membrane. This is serous otitis media. Air fluid levels behind the tympanic membrane can be appreciated, which can't be appreciated in this picture, but trust me, they can be. Okay. Then we have age of presentation of acute otitis media is 6 to 18 months or 5 years. Risk factors include lack of breastfeeding, daycare attendance, cigarette smoke exposure, and recurrent upper respiratory tract infection. Otoscopic findings decreased mobility on the pneumatic insufflation. This indicates middle ear effusion. Bulging of tympanic membrane, this indicates middle ear inflammation. Fever, hearing loss, and tympanic membrane erythema are also present but not required to make the diagnosis. So this is what we see in that. I don't know what are they trying to do. they are doing what? I have no idea. So the management, in age less than 6 months, we give amoxicillin. If the age is more than 6 months, high fever, severe pain, or bilateral disease, give amoxicillin. Low fever, mild or no pain, and unilateral disease, give analgesia and observe the patient. More than 3 episodes in 6 months and more than 4 episodes in 12 months, you can do tympanocentesis and culture during meningotomy with uh, tympanostomy tube placement or when persistent more than 3 months. Okay, so if age is less than 6 months, amoxicillin. More than 6 months, for high fever, severe pain, bilateral disease, give amoxicillin. Low fever, mild or no pain, unilateral disease, analgesia and observation can be done without giving amoxicillin. If there are more than 3 episodes in 6 months and more than 4 episodes in 12 months, so tympanocentesis and culture during meningotomy is basically putting a hole in the tympanic membrane which will drain the fluid in the middle cavity, and we can do that culture and we can see which organism is causing that trouble. With tympanostomy tube, a small tube is inserted in the tympanic membrane so that excessive amount of the fluid which is not drained right now can be drained later on. Okay. So differentials include CSOM. CSOM is chronic suppurative otitis media, right? So more than 6 week history, and otorrhea. Otorrhea means water discharge from the ear. Serous otitis media, lack of acute inflammatory signs. So in serous otitis media, inflammatory signs are not there, like fever or tympanic membrane bulging will not be seen. Rest aside, it is a similar condition. So these things are differentials of acute otitis media. Then acute otitis media, the microbiology is Streptococcus pneumoniae, non-typable Haemophilus influenza, and Moraxella catarrhalis. The clinical features include bulging tympanic membrane, middle ear effusion with tympanic membrane inflammation, and fever, otalgia, and erythema. Treatment, initially we give amoxicillin. Second line is amoxicillin clavulinate. If not resolved with amoxicillin, give the combination of both of these things. Like amoxicillin clavulinate. Clavulinate is basically beta lactamase inhibitor. It inhibits the beta lactamase enzyme, which normally inhibits activity from amoxicillin. Then penicillin allergy, if the patient is having penicillin allergy, we can give clindamycin or azithromycin. Complication is tympanic membrane perforation, conductive hearing loss, mastoiditis, and meningitis. These same bugs like strep pneumo, Haemophilus influenza, Moraxella catarrhalis can be seen in the acute bacterial rhinosinusitis, acute otitis media, and bacterial conjunctivitis. The next thing is about the otitis media with effusion, which is also called as a serous otitis media. It is defined by the middle ear fluid without tympanic membrane inflammation. Distribution is in the young children aged 6 to 24 months. They are predisposed to fluid accumulation within middle ear due to narrow, straight eustachian tube that drain poorly. Most effusions develop in setting of viral infection or following an episode of acute otitis media. The presentation is the child will come, the parents will come with a complaint of the child doing excessive ear tugging and no fever or severe ear pain. Examination will show air fluid level posterior to the tympanic membrane, poor tympanic membrane mobility or pneumatic insufflation. Tympanic membrane is not bulging or erythematous. Effusion is non-purulent. In contrast to acute otitis media, in which the effusion is purulent and tympanic membrane is bulging or erythematous. Management. Resolution within weeks or no treatment is required. Follow-up. Patients should be followed up because of chronic otitis media with effusion for more than 3 months. Can cause speech delay and long-term hearing loss. Tympanostomy tube placement can be used to manage the chronic otitis media with effusion. Then these are suppurative complications of otitis media. I think we have seen this picture before. So they can be mastoiditis if it goes downward. They can be brain abscess if it ascends upwards. They can be meningitis as well. And they can be labyrinthitis, which they have not mentioned for some reason. So the next thing is Rini and Weber test. So the interpretation of the Rini and Weber test is that normal Rini test is that air conduction is more than the bone conduction in both ears. Conductive hearing loss shows bone conduction more than the air conduction in the affected ear, while air conduction more than the bone conduction in the unaffected ear. Right? Sensory neural hearing loss means air conduction more than both bone conduction in both ears. Mixed hearing loss is bone conduction more than air conduction in the affected ear, while air conduction more than bone conduction in the unaffected ear. Basically, the uh, pattern of conductive hearing loss, if both of them are present, so the pattern of conductive hearing loss dominates. And normally, the Weber is midline. In conductive hearing loss, the Weber lateralizes to the affected ear. Okay. In sensory neural hearing loss, it lateralizes to the unaffected ear, away from the affected ear. Okay. And mixed hearing loss is lateralized to the unaffected ear, away from the affected ear. So basically, the point of all this discussion is you can see that normal and sensory neural hearing loss is giving the same Rennie test, right? Now, after, if we get this result, we perform the Weber test. If the Weber test is medially, if it is in the midline, so it's okay. But if it is lateralized to the one side, so it means that side is having a problematic ear and that side is affected. Okay, and that side is having sensory neural hearing loss. Now, this is how we perform the Weber test. This is normal. Equal hearing, normally it lateralizes equally to the both sides. In sensory neural hearing loss, no, in conductive hearing loss, it is louder on the affected ear. Why? Because on the affected side, suppose there is no conduction, so the external hindrance of the sound cannot enter, so the sound appears to be more pronounced on the affected side, right? So this is the concept of lateralization in the Weber test. And the sensory neural hearing loss, it is louder in the unaffected ear because it is basically bone conduction, right? So when the nerve is not functioning properly, so the vibrations which are reaching the cochlea will not be transmitted. So that is why the unaffected side appears more pronounced. So these are healthy ears, external or middle ear disease decreasing on the room temperature, and inner ear disease decreasing on the room noise and tuning fork. I hope that made sense. Then eustachian tube dysfunction. Physiology. Eustachian tube normally opens and closes to equalize the middle ear pressure and drain the middle ear, prevent the reflux of nasopharyngeal secretions. Pathophysiology. Inflammation, for example, infection, allergies, and environmental irritation will lead to tube obstruction. Signs and symptoms: ear fullness and discomfort, tinnitus, conductive hearing loss, and popping sensation. Management: treat the underlying cause, for example, antibiotics for acute bacterial rhinosinusitis. Then these are cholesteatoma. So cholesteatoma is a benign condition. Firstly, I would like to mention that, and it has nothing to do with cholesterol. So this is a cholesteatoma. This is Malleus, incus stapes, and tympanic membrane. These are pearly white mass. Retraction pocket is formed in the tympanic membrane in which the cholesteatoma can form. And this is epithelium and keratin debris basically. It is a benign growth of squamous epithelium and accumulation of the keratin debris within the middle ear. Risk factor: history of recurrent otitis media, chronic middle ear effusion, and tympanostomy tube placement. Presentation is chronic otorrhea and conductive hearing loss. Examination will show a pearly white mass, most commonly in the anterosuperior quadrant of the tympanic membrane. Visible retraction pocket with the draining debris will be present, and treatment is surgical excision. The next thing is about the something that is acute rhinosinusitis in the children. The clinical features are nasal congestion and or purulent drainage. Facial pressure or pain will be there, with or without fever, cough, headache, loss of smell, and ear pain. Etiology: mostly the etiology is viral. Okay, just give me a second. So I'm sorry, the etiology is viral. Like they will, if it is viral rhinosinusitis, so there will be no fever or early resolution of the fever. Mild symptoms, for example, well appearing and mild facial pain. Improvement and resolution by the day 5 to 10. If it is bacterial, so fever will be there for more than 3 days, or new recurrent fever after the initial improvement, or persistent symptoms more than 10 days. Treatment is intranasal saline irrigation and NSAIDs, antibiotic if bacterial. Acute bacterial rhinosinusitis, most common cause is non-typable Haemophilus influenza for the bacterial rhinosinusitis in acute settings. Therefore, the other causes are Streptococcus pneumonia and Moraxella catarrhalis. Same organism as acute otitis media, right? So most common presentation is nasal discharge and cough for 10 days or more without improvement. In contrast, viral rhinosinusitis improves by day 7 to 10. Criteria for diagnosing acute bacterial rhinosinusitis: any one of the following three. Symptoms persist for more than 10 days. Symptoms severe in onset more than 39 degrees Celsius with drainage for more than 3 days. And symptoms worsen following the initial improvement, that is biphasic illness. Fever may be absent. So these same bugs are also present in acute bacterial rhinosinusitis and acute otitis media and bacterial conjunctivitis. Treatment: severe symptoms or worsening, give amoxicillin with or without clavulanate. Mild symptoms or persistent with no worsening, 3-day period of observation and oral antibiotics can be given. Complication is periorbital, orbital cellulitis, meningitis and vein abscess. Postorbital septal involves the ocular muscle, the ocular muscles. The preseptal does not have ocular muscle involvement, so movement is normal. Okay, that was something that I'm not very clear about. They're saying that there can be preorbital or orbital cellulitis. If it is postorbital or orbital, septal what? Okay, they're trying to say that if it is preorbital or post, or okay, that does not make sense at all. The preseptal does not have ocular muscle involvement, so movement is normal. Okay, blah, just forget about this. And if you can understand, please make me understand as well. So the next thing is something. Okay, so this is about the acute bacterial rhinosinusitis. The differentials are: acute viral rhinosinusitis. Symptoms typically resolved by the day 10. Symptoms are mild. Example: no fever or early resolution of fever and mild pain. Management is nasal saline and irrigation with NSAIDs. Acute bacterial rhinosinusitis, the clinical features are cough and nasal discharge, fever and face pain and headache. Diagnostic criteria: 1 of 3. Persistent symptoms for more than 10 days without improvement. Severe onset of fever more than 39 degrees Celsius, 102.2 degree Fahrenheit, drainage for more than 3 days. Worsening symptoms following the initial improvement. Treatment is amoxicillin with or without clavulanate. Nasal foreign body. It can sound like a benign condition, but it can become very, very dangerous at times. Clinical manifestation: inorganic substance like asymptomatic, mild pain and discomfort. If it is organic substance, unilaterally can be very false smelling and give purulent discharge. And if it is a button or a battery, it can lead to epistaxis or a purulent discharge. Treatment: positive pressure, for example, patient exhalation with unaffected nares occluded. Mechanical extraction. Complications: infections, for example, sinusitis, local irritation, aspiration to the airway, nasal septal perforation with button battery or multiple magnet insertion. Yeah, nasal septal perforation can occur with a button battery or multiple magnet insertion. Then the next topic is about the thyroglossal duct cyst. So thyroglossal duct cyst is a midline mass which appears in the pathway of the normal development of thyroid tissue from the tongue. Actually, there is a thyroglossal duct which forms at the base of the tongue and then it descends downward all the way to the thyroid, where normally the thyroid resides, and the duct then involutes. But if the duct persists or if there is some sinus inflammation in that, so this will lead to this formation, like there will be thyroglossal duct cyst formation. What is superior MOBD? I don't know, but this is thyroglossal duct. The pathophysiology of this is: thyroid gland is formed as an outpouching from the pharyngeal epithelium at the base of the tongue. It then descends to the base of the anterior neck via thyroglossal duct. If the duct fails to atrophy normally, a thyroglossal duct cyst can develop from the epithelial remnants within the duct, forming the midline cystic mass. Since the tract connects to the base of tongue, protrusion of the tongue or swallowing causes the thyroglossal duct cyst to move superiorly. It is an important clinical test as well. Thyroglossal duct cyst is often detected when it becomes secondarily infected after an upper respiratory tract infection. Treatment is surgical removal. Thyroglossal duct cyst is often associated with the ectopic thyroid tissue and may be the only source of functioning thyroid tissue. Thyroid imaging is required preoperatively. Then thyroglossal duct cyst embryology forms along the path of thyroid descent. Foramen cecum, base of the tongue to the base of anterior neck. Okay. Clinical presentation is midline cystic mass, moves superiorly with the swelling or tongue protrusion. Then we have often present after upper respiratory tract infection secondary to the infection. That is important. That thyroglossal duct may be persistent, but it does not present with any symptoms. The symptoms they present only when there is upper respiratory tract infection, some trigger, right? Okay, associated with ectopic thyroid tissue. Management: confirm the presence of the normal thyroid tissue. Surgical resection of the cyst associated with the tract and central portion of the hyoid bone. It was a central mass, that is why it is called thyroglossal duct cyst. If it would be a lateral mass, it will be bronchial cyst. Thyroid migration. So this is the normal pathway of thyroid migration. Like this is foramen cecum. This is okay. This is not a pathway. This is a pathway. It is formed here. If it does not move from here or persist here, it is called the lingual thyroid. Then it moves downward like along with these arrows and here, and the normal location is this. If thyroid tissue remains midway, so it can form pretracheal thyroid, sublingual thyroid, or lingual thyroid. And this blue one is a path of the thyroglossal duct. Pharyngitis. Pharyngitis can be viral, more common in age less than 5 years, or bacterial, like tonsillar erythema and exudates, tender anterior cervical nodes, and palatal petechiae. If rapid streptococcal antigen test is positive, give amoxicillin as soon as possible. If it is negative, give a throat culture before prescribing the antibiotics. Evaluation and management of pharyngitis. The center criteria: fever by history, tender anterior cervical lymphadenopathy, tonsillar exudates, and absence of cough. If it is for 0 to 1 days, no testing or treatment for streptococcal infection. If it is there for 2 to 3 days, rapid streptococcal antigen test can be done, penicillin or amoxicillin for positive results. If it is there for the 4, it is not days. If none of these symptoms, I would repeat them: fever by history, tender anterior cervical lymphadenopathy, tonsillar exudates, or absence of cough. If 0 or 1 of them is present, so no testing is required for the streptococcal infection. If 2 to 3 of them are present, then rapid streptococcal antigen test is done. If it comes out positive, give penicillin or amoxicillin. If all 4 of them are present, like there are 4, or do the test, or maybe you can start with the empiric penicillin or amoxicillin. The center criteria is reliable for adults but not for children. For children, look for symptoms. So the viral symptoms include cough, rhinorrhea, conjunctivitis, and oral ulcers. Bacterial symptoms are exudates, edema, palatal petechiae, absence of viral symptoms like these. ASO titers can be obtained after 1 month because the ASO antibodies peak after a month. So we have to treat the patient in the meanwhile. The next is, what is it? Sinus what? Okay, I can't even pronounce it. Sinusitis, titbites. Okay. The clinical features: sore throat, dysphagia, odynophagia, pharyngeal tonsillar erythema. Presence of viral symptoms, for example, cough and rhinorrhea, conjunctivitis, or oral ulcers. It can be viral pharyngitis, and you should give symptomatic treatment only. Presence of exudates, edema, palatal petechiae, absence of viral symptoms. Do the rapid antigen test. If it is negative, do the throat culture. If it is also negative, then it is most probably viral pharyngitis and symptomatic treatment is done. If throat culture is positive, or if the rapid region test is positive, it is streptococcal pharyngitis, and penicillin or amoxicillin is given to these patients. Then comes this disease, that is sinusitis, titbits. Okay, Staph aureus causes chronic sinusitis with inflammation for more than 12 weeks. Staph pyogenes rarely causes sinusitis. It causes pharyngitis without cough or nasal discharge. Whereas in acute bacterial rhinosinusitis by Haemophilus influenza, both of these symptoms are present. Fungal sinusitis presentation, so occurs only in the cases of impaired host defenses, diabetes mellitus, or malignancy. Signs and symptoms include epistaxis, turbinate destruction, palatal eschars, and maxillary cyanosis. Pediatric obstructive sleep apnea is an important topic. Pathophysiology of OSA will show adenotonsillar hypertrophy. Clinical manifestations include night symptoms like loud snoring, pauses in breathing and gasping, enuresis, and parasomnia, sleepwalking, and sleep terrors. Day symptoms include inappropriate naps or falling asleep during the school, irritability, inattention, learning problems, and behavioral problems, mouth breathing and nasal speech. Complications include poor growth, that is failure to thrive, poor school performance, cardiopulmonary, for example, hypertension, structural heart changes, and tonsillectomy and adenoidectomy. Evaluation of obstructive sleep apnea with a nocturnal polysomnography sleep study, which detects and quantifies respiratory pauses and desaturation during the sleep. Treatment of obstructive sleep apnea, for example, tonsillectomy and positive airway pressure, can lead to resolution of the associated aneurysms. So that is all about ENT. We'll continue with the GIT in the next session. Until then, Allah Hafiz, Fi Amanillah, and take care.